Okay. So everybody's here?
Yes, sir. There may be some beyond.
Okay. So most everybody was here for the last time we did the lecture on nodules. Or is anybody who was new who wasn't here? You weren't here for the November. Anybody else? Okay. I'll start at the beginning, just kind of do a rapid review of some things and we'll go on to the next. So Dr. Ricky asked me to talk about pulmonary nodules and lung cancer. Those are two big topics. Lung cancer, I'm not going to focus as much detail on, but what you need to know as a primary care physician about lung cancer, about nodules, about what should you do? What should you do with a nodule? When should it be biopsied? Should you biopsy it at all? When do you watch it? How do you follow it? Those are basic things that you can do. I think the main thing is to know when is a pulmonary consult needed. If you're not sure, go ahead and do that. If you're not sure, we have a lot of people who get referred for quote biopsy and they go ahead and get a CT biopsy when that really isn't what they needed. So many people need biopsy, many people don't. So I hope that I can help you at least know when it needs to be a biopsy, or if you're not sure, then pulmonary consultation. So we talked last time a little bit about nodules. They're 30 millimeters or less. They're solid, subsolid, or pure ground glass. And I'm going to go fast through the first 20 slides because that was the first lecture in November. Here's a solid nodule. Here you can see on CAT scan even looks spiculated. Semi-solid, ground glass nodule here, not FDG avid as most ground glass nodules. And here one that's semi-solid. Why is that important? Because those calculate into your risk. Solid nodules, not as high a risk as a semi-solid. Okay, majority of the nodules are benign, so that's a key point. If you look at studies at the Pan-Canadian early detection, 12,000 nodules, only 144 are malignant. So about 1%. So the majority of nodules out there that we're screening and looking for are benign. Problem is, not all of them are. They are benign, to be simple, but there's some malignant. So where are those? And that's where you have to risk stratify to be able to find out who those are. So I mentioned last time, what can you ask? What tests can you do? And we went through those the last lecture in November. When should you biopsy? How should you biopsy? I think how should you biopsy is the most up in the air. I see some patients, as I told you, a patient who I was looking at, they had asked us about, it had already been biopsied. They had an upper lobe nodule. They came in, the team on the floor ordered CT biopsy of the nodule, came back Staph aureus. Well, if you ask that patient's history, he aspirates all the time. He has nodules that come and go. So he just was colonized and aspirated, and he had an aspiration, pneumonia, and all they did was aspirate one of the nodular infiltrates. So by history, you probably could have gotten that and he wouldn't have to have a biopsy or a potential pneumothorax. He didn't get a pneumothorax, but he could have had that. So we want to avoid pneumothoraces if we can. If you have to do it, you have to do it, but you want to make sure that you need to do that. You don't want to create a complication in a patient who didn't even need a procedure. So when should you biopsy? How should you biopsy? These are questions that I'll go back over at the end. What can you ask? And this goes into the lung screening program that I'm going to talk about a little bit today. Y'all have heard about the LDCT program, the lung screening program. So the two areas and nodules that you want to look at, is a patient qualified for lung screening, or they just have a nodule? They're not a smoker, you just have a nodule. That's in the Fleischner category, and you have the lung screening category. Okay, so those are two different categories we deal with when we're looking at nodules. Which category is a patient in? And that's how you decide. So if a patient's between 55 and 80 and they've smoked more than 30 pack years and it's been less than 15 years, then they qualify for that program. And the USPTF that I'm going to talk about, they've dropped the age to 50 and dropped the pack years to 20. And so we should be doing that. If you have 20 pack years and you're between 50 and 80, you should be screened. And so we'll talk some more, we'll come back around to that, some more detail. Questions to ask, as we did with that patient who had the Staph aureus. He had some swallowing difficulty as a previous stroke. He had a little bit of sleep apnea that was not treated, and he had some poor teeth. So clearly that guy would aspirate. Family history of cancer, weight loss, other types of cancer. Imaging, we talked about that last time, so I won't go into that. Let's just go to some of the imaging here. As you know, I showed that nodule last time. This is atypical mycobacterium. The calcium point suggests there might be something else that might be benign, but you need history. If that's the only nodule I saw and the patient is a 55, 80 big smoker, I would probably not just say, well, that's mycobacterium. I would try to get a induced sputum to see if I could get up MAI. And if I did, then I might observe the nodule a little bit, but I'd have a low threshold. If this nodule is 2 centimeters or greater, I would probably consider biopsy. And I've had done that. Some of my MAI patients that I'm already treating for MAI, they come up with a nodule, it keeps growing, gets bigger, it's FDG positive, FDG avid, a biopsy, and it's granulomas, MAI. But they have it, they have a risk factors. They have the risk factors for it. And so lots of people have more than one disease, as you know. Lots of people have, one man has 6 cancers all at the same time. So Dr. Gefter calls them cancer farmers. They're harvesting cancer. They seed cancer, fertilize it, grow it, harvest it. And so you'll see patients that have that. As you know, it's related to the immune system. Here's a calcified granuloma nodule here. You can see it's got calcium there. So that indicates that that's benign and nothing needs to be done for that. This nodule has a lot of fat here and was followed for 2 years. That would be a hamartoma. All right, calcifications with a hamartoma there. So now I think we're coming up to where we were last time. Not all nodules are malignant, as this is a pulmonary infarct, and you'll need history to determine that. You can see it's FDG avid. And so that can be mistaken, and it can be difficult many times, and you have to go through a process to decide whether you should biopsy that or not. I would say in general, you don't read this in the literature, but a doctor who's following a patient with a nodule, if you're following it and they're following up, they're in a much better category than if they're just gone. So if you're not sure about the nodule, but you're watching it, it's going to be rare that it's going to get away from you. It could go fast, but if the patient's following up and coming and you're watching it, that patient's much better off than if they're just out there with no follow-up at all. So we ended last time, I think, talking with these, correct?
Yes.
So this is, I want to emphasize again, is important because you don't want to biopsy these. What is this? Well, it's already told you here. You want to look for a tail of blood flow that might be a vein or an artery that's supplying that. You don't want to biopsy an AVM. And so many times if we're not sure or we're looking at a non-contrasted study and look at it, we'll go ahead and just do a contrast study and see it. If it lights up an AVM, then of course that proves that you don't need to biopsy that. But that is something you do not want to put that patient to go to CT biopsy, to nodule, to biopsy that. You can see some others where you see a trailing vessel or entering vessel and vessel leaving here in B. There with the feeding artery is the dashed arrow and the draining artery, the arrowhead. And so that's important to look at. As you can see, another one over here on C and another one over here. So you have to watch for those. And we don't have too many of those. Typically, you're going to have AVMs. You're going to get some history sometimes to suggest that that's what they have with hemoptysis. So you're calculating the risk. I don't know that we talked about this the last time. You have a risk calculator and up to date. And what you're trying to decide is by risk. Let me go to this slide. Low risk. So you've got a 5 millimeter nodule in a young patient, non-smoker. That's a low risk patient. That patient doesn't need anything. That's simple or straightforward. You have a high risk patient. He's got a 3 centimeter giant nodule, long smoking history, treated with lung cancer 10 years ago, having some hemoptysis. That's a high risk. And you know what to do with that. You have to work that patient up, go ahead and make a diagnosis and biopsy. The difficulty is the moderate risk, which is a large category. What do you do with these patients? And that's why you have to go through and make a decision. Are you going to biopsy? Are you going to watch it? what you're going to do or what test can help you. How does the history help you and the patient as well? All right. So when it says here on Zoom, admit, should I go ahead and do that there?
Thank you.
So we have some on Zoom.
Yes.
So let's go back. So the age of the patient, as we talked about, 55 to 80. And the oldest patient I've done a super D navigation is 92. Man had a nodule up around the periphery with some blebs around it. They said, no, I want treatment. I want to live. I got to take care of my wife. We've been married 65 years. So we went ahead and did navigation. He had an adenocarcinoma. He got radiation and did well. So just because they're beyond 80 doesn't mean you can't treat them. He was very healthy, a healthy 91. So we have some healthy 91s, but much healthier than a lot of the 50-year-olds I have in my clinic, as you have as well. So, but to calculate the risk, if they're, and that would be right here, 35 to 39, as you can see, estimated risk by age goes up. And so it kind of crosses there at 50, and that's where we get this cutoff for screening and starting to put people into the screening program as it really jumps up at age 50 to 59 and then on up from there. So age, major risk factor. Sex, women smokers have a higher incidence of malignancy than as lung cancer. As you know, lung cancer passed breast cancer in women in 1986. Dr. Trulock used to have a slide about Virginia Slim, said, "You come a long way, baby. Look here, you passed breast cancer as the #1 cause of death in women from cancer." And that is because the Surgeon General's report that said smoking is bad in 1967, that came out, men really traveled off, smoking went down, women kept going. And so the track for lung cancer and COPD in women is still rising. Not as much in men because they started cutting back that, but COPD is actually a women's disease. More women have COPD than men from 2000 forward. So family history of lung cancer, smoking history, nodule size, we're going to talk about that. Nodule type, we talked about a part solid nodule, higher risk than a solid. And the nodule type, it has calcium in it, then it would be benign. Why a nodule in the upper lobe? Why is that a higher risk? What's that? Right, you have more smoke there. So they have a higher concentration of smoke going to the upper lobes. That's why we see more emphysema in the upper lobe, right? Smoke comes up. And so you have a higher smoke exposure. So upper lobe lesions, probably about 2/3, the majority of the lung cancers we see are in the upper lobes. You can have them in the lower lobe. But upper lobe is a little bit higher risk. Nodule count. So if you got multiple little nodules, probably not as bad as one big nodule. And speculation. So let's go through some of those. Nodule size, less than 5 millimeters. So I'm going to show you a table with the Fleischner criteria. And if you have a nodule that is under 6 millimeters, then you should not biopsy that. Why should you not biopsy it? Anybody? A CAT scan, got a 5 millimeter nodule. Why not biopsy that? Pretty hard to miss. Hard to hit. Okay. I might get the needle, just magnify this. There's the nodule. I might get the needle right there next to it, but you can't see that on CAT scan. Be one reason. Number two, another reason why a biopsy 5. No, most of them aren't malignant. Cancer malignancy is low. That's the biggest reason. Another reason. Right. PET scan doesn't help you. It's too low. And if this is the only thing we're dealing with, that's it. You don't have anything else. And you really think it's malignant, you should take it out. All right. Well, I don't need to really biopsy it. So 5 millimeter nodules, they're very hard to navigate to. They're hard to biopsy. They're low risk of malignancy. So you watch those. I watch, at least I do. Everybody else generally does. The general rule in the national standard or across the world is in anything under 8 is watched. And that's where you see most of the risk categories, what they're done with. FDG avid nodules, PET scan doesn't work below 8. There's not enough cells to generate an FDG signal. And do you all understand what I mean about the PET scan, the FDG, the fluorodeoxyglucose? So you have a sugar molecule with the Tennessee flag on it, right? You have football fans out there, orange flag. So those cells that are eating, that want to eat, are going to have a lot more orange flags to make a signal. And so that's what you come across with the orange signal that you can see. But with the sub 8 millimeter nodules, there's not enough of those molecules to give a signal that can be picked up accurately. So PET scan not really helpful really below 10 almost. So 8, 9 is kind of borderline. You may have an extremely hot lesion. It might show up a little bit if it's 9 millimeters. All right, so 5 to 9 is 2 to 6%. You can see the big jump goes at 8 to 20 millimeters. That's an 18%. We're talking here, 1 out of 5, 1 out of 6 patients with that nodule may have malignancy. That's a big jump from 2 to 6, where it might be 1 to 50. So when they get to be 8, mostly I'm concerned when it gets to be 10, I use that kind of as a general rule, but 8 to 10, you have something, you got to pay attention to it and make a decision. And clearly nodules that go above 20 millimeters, very high risk for malignancy. So we've talked about nodules less than 8, chance of a malignant is low. They're difficult to biopsy, as we just talked about. It won't show FDG avidity on a PET scan. All right. So this nodule, I'm just showing this to show you that it's spiculated, looks bad. And if you measured it, probably would measure 25, maybe even 30 across. So that's cancer till proven otherwise. You have to prove that you need to make a diagnosis if that patient decides he wants treatment, wants to be treated. So let's talk about the first category for nodules when you see them. So we have the LDCT group here and Fleischner over here. Fleischner is all nodules in people that are not in LDCT, but they put also, it's not applicable to patients less than 35, a patient in the lung cancer screening, immunosuppressed, known pulmonary disease, or symptoms of active primary. Now, if you have a patient with COPD who's not a smoker, he would go in this category too, still. Not in the low dose screen, you have to be a smoker to get into that. All right. So you find this nodule, what do? Well, this is the Fleischner criteria. So you have either low risk or the high moderate risk. You say, well, I don't know which one. Well, you can use your risk calculator. Up to date has that. And it has all those parameters that I just showed you about age, size of nodule, multiple nodules, single, spiculated. So it's on up to date. If you go risk calculator for lung cancer, you can find that. And then you can put them in the risk and then see. But you have a patient who's low risk. They have a nodule that's 5 millimeters. You don't have to follow that. I don't see most of those patients. Most of the ones that come to my clinic are smokers when I get a nodule. They're older, they've smoked, they have COPD, might even have a history of cancer. So I rarely get a low risk patient, but you all might get a lot of them. And so those don't need routine follow-up. If it's 6 to 8 millimeters, then you can do a CAT scan at 6 to 12 months and then consider repeating it. Basically, what you want to do is follow a nodule 2 years, depending on the risk. If they're high risk and you have a ground glass nodule, you might follow that a little longer. I had one lady who had a previous lung cancer, ground glass, BAC, came to us as a mother of one of our doctor physicians here. I followed it 7 years. It went from 7 to 14. It took 7 years to double. So when I first saw it was 7, I said we'd follow it again. It didn't seem to change. It seemed to change a little bit at 2 years. She had a previous, I kept following. She didn't want anything done. Finally got to 14. She says, I think I want to go ahead and have some. She wasn't sure. So it was 14. I told Dr. Zellner, who was a thoracic surgeon, I said, I followed 7 years. He said, 7 years? I said, yeah, but she wants it out. So he took it out and it's a BAC again. And so sometimes you need to follow longer. That lady was at higher risk, but that's not the normal. No, Dr. Ball said I can follow them 7 years. That's not the usual. You'll follow these 2 years is what you'll follow. Greater than 8 millimeters, you can go up at 3 months, and then you double that if it didn't change. 6 more months would be month 9. So now you're at 12 months. It hasn't changed. You do another 12 months. So you did it's 3, 9, and 24 months. Does that make sense? Okay, questions about that? I'm gonna go on because I want to get to cases. So to make sure that we have time to talk about that, and time goes fast. So the National Lung Screening Trial, we talked about this, is from the risk calculation, the NSLT. So patients that were 55 to 74, they took actually large gate group, went beyond that, and then they cut people back according to, and looked at statistics to see where it was significant. And they found in this age group of patients who had smoked more than 30 pack year, less than 15 years since they had quit, the relative mortality reduction was 20% in the group screened compared to those who weren't. And so that's what we explain to patients. And that's what you should explain. You have a smoker still smoking, then talk to them about this. Why do we have a lung screening program? And this is talking here now in this group. Why do we have that? Well, the mortality in lung cancer is pretty poor, and I'm going to show you that. Most of the cancers that present are what stage? Today. It's changing, but what has it been normally? Yeah, why is that? Because 4 is symptomatic. 4 presents with rib pain, bone pain, seizure, head bleed, something else going on. But the cat's out the back, stage 4, pleural effusion, stage 4. Stage 1 doesn't have any symptoms. So how are we going to change the mortality for lung cancer? How are we going to change that? What's the number one way to change it? Stop smoking, right? I don't have time to talk about the smoke bus. One of the rest asked me. That's when we're going to talk about smoke bus again. Not this time, but stop smoking. That's clearly related. And so I have patients who come to me, they're coughing, they're coughing. I say, yes, the smoke. You got to cough. And you smoke, you stop the mucociliary elevator. It doesn't even work. The only way you're going to survive is to cough. Cough's keeping you alive. You want me to stop something, you're going to die. If I stop the cough. Oh, keep looking at me like that. You're smoking, you're going to cough. That happens. You have to keep alive. But the cough is keeping you alive. If we get off the smoke bus, that'd be different. So stopping smoking. How else can we change lung cancer mortality? Early detection. So early detection really is both these categories. And that's where the lung screening comes in. So that we detect the group that's the highest risk by looking with binoculars that we'll call a CAT scan. So we're watching the group that I think we're going to see some cancers grow. Not over here, where it's in the desert. I want to watch the lung cancer where it's growing. And that's these group of people. Okay, cancer farmers, Dr. Geffter says. They're out there growing seeds, looking to see if we got cancer yet. Not yet. That's my smoke. That's what you're looking for. You're looking for cancer. Growing seeds out. We got a cancer yet? Not yet. I have to try next. So they're looking for it. Okay, when they have it. So early detection, lung screening. And that's where the CAT scan comes in. Chest x-rays were used a long time ago. They weren't helpful, but we have to look at lung screening. And then in those nodules that look like they're suspicious, what tools do we have to diagnose those smaller nodules? And that's what I'm going to talk a little bit about the technology of that too. A little bit. Okay, so the USPSTF came in with screening. We need to go to even enlarge that circle a little bit bigger to age 50 and 20 pack, and that gets a lot more people in. And so that's what we're doing now as well. And so if people are smoking, we tell them, we go through that, explain the risk reduction to them. A discussion, Medicare requires that. It does require that you discuss what risk, the risk of doing a CAT scan every year and the radiation. And I explained that there is a slight chance, 1 in 100,000 or less, that you could have some complication from doing that, from doing a CAT scan. There's also a risk that we will find something that looks like it's suspicious and do a procedure that could have risk. But that's something you have to explain as you get through that. So you discuss the risk and the benefits to screen, and most people agree. I have some people who say no. So I had one lady and she had a nodule. She said, I don't want anything done. So that's what I'm talking about here when we get to biopsy. What's the patient's wishes? She says, I I don't want to think about cancer. Just, I don't know. Yeah, so what's it? Just how long am I to live? We talked about that. Make a decision. He said, I don't want any tests. I don't need that chemotherapy radiation. So what's the patient's wishes? They don't want it. That's fine. It's good when you're doing that and they do refuse to document that. And if you have a family member to get involved in it, another there who's with them, that can be an advocate for the patient. There are patient advocates there and document that if they don't want to go forward. And always include counseling towards smoking cessation. So in the lung rads category, we have 1, 2, 3, 4. This chart's too small to see for the patients who qualify, but I just had to point out a couple of things on it. So it's based on the size of the nodule. Is it solid, part solid? The size of it, how big it is. As it gets bigger, it goes down from 1, 2, 3, 4. You don't see any nodule or nothing. It's a category 1. Less than 6 would be category 2. Basically, you don't have to know all that. Just look up lung rads on your phone and you can get this table. All category 3 and 4 nodules are discussed at thoracic conference, and we look at them to make sure that they are 3 or 4. And to make sure that those 3 or 4s get follow-up and get referred. If we miss a category 2, we don't need to see those. They don't need another CT till next year anyway. Okay. So the 4A is a solid nodule that's greater than 8, less than 15 at baseline or growing. Those people need something else done. Okay, so you have 12-month here, 6-month here, 3-month here. Maybe they need a PET scan. Have to decide if it's a nodule growing. Okay, a 4A and 4B is a higher risk, and a 4X is 4A, 4B that has even more characteristics that make it malignant. So 4A, 4B, 4X, you need to do something about if the patient wants that and make that decision with them. So you can look up lung rads and put that in your phone, and we go over all the 3 and 4s. So decision-making for biopsy. If you have a single peripheral FDG avid nodule, the guidelines saying the patient can be offered, you have a CT scan, you've got one nodule. Let's say it's 12 millimeters or 15 millimeters. That looks like about 15 or 16, and it's FDG avid. And you have nothing else added. Okay, nothing else lights up. If you have an enlarged node, you can still do EBUS and look at it. And we'll make a decision about that. What's the next steps you should go through with that patient? Well, talk to the patient. What's their wishes? I don't want anything done. Okay. You know, make sure you go through that. Explain to them. This we think is we have a single nodule here. We did a PET scan. It lights up. The patient's pulmonary function test, and won't go through the details of that, are very good. He has an FEV1 that's greater than 80%. His DLCO is 90%. He's an operative candidate. Doesn't have a lot of comorbidities. The guidelines say to take that out. You don't need to biopsy that. Why? You biopsy it's malignant. You're gonna take it out anyway. So a negative or positive biopsy doesn't change what you should do, right? So single lesion, don't need to biopsy. They find out the patient's wishes. Treatment. Explain that to them if a diagnosis is made. Some patients do want a diagnosis and aren't sure they want treatment, and they want to know. And we will do that sometimes biopsy to help them decide, because some you find out. I had a lady not too long ago, hot nodule here, hot lymph node here. She wasn't so sure, but she said she wanted to go through with it. We went ahead, and guess what we found? Histo. And chickens. Oh, she had a subclinical histoclast. So she was happy for that. Didn't have to worry about it anymore. That's what caused cancer. So she went on her way. She's fine. She wasn't so sure she wanted any treatment. She was glad she had the biopsy. Can the patient tolerate a procedure? Will their lung capacity permit it? Are they on Coumadin because of atrial fib? You're going to have to take them off that. Can't biopsy. Never biopsy body on Coumadin. You can't biopsy the lymph nodes. We go near the major vessels, the aorta. You stick the aorta or the pulmonary artery. They're on Coumadin. It's a disaster. So they have to be off Coumadin. In some of those cases where it's real critical, I always talk to the doctor, the cardiologist, ask them, the neurologist. I had one patient had a posterior cerebral artery stent put in. And had some strokes, and I talked to qualified. No, you can't take them off bladders. Can't. I told them that, so we're gonna have to watch it. Turned out as we watched it, it shrunk. So I never had to take it off anyway, never had to do the biopsy. But part you can't be off. You said his risk of stroke is too high. Other patients with cardiology, if you can't take them off, sometimes you have to bridge them. So you may have to put them on Lovenox, stop the Lovenox the day before, and then start them right back on it after, and then get them back on Coumadin. There's other things that you can do, but can they tolerate the procedure? Are they going to be able to do that? So let's say they want treatment, they want to go forward, they can tolerate the procedure, they can be off the Plavix, they can stop the aspirin, Plavix, Coumadin. Is there a pathway to the lesion? Is there a pathway to the nodule? I always look for that first. So when they need a biopsy, I don't go to CT biopsy first. Okay, I look first if it can be biopsied. So if it looks like it can be biopsied, this one, I'm just going to do, we'll try to get to some cases. We have this nodule here. Okay. I haven't got a PET scan yet, but I want to do one. Why? That's the next step, is prepare. Is there a pathway to the lesion, and do we have a PET scan? And do we have a previous CT scan? Do we have any previous scans? They're important questions. So why do we want a PET scan? Okay. FTG avid is hypermetabolic. Number two, what do the lymph nodes look like? They may be normal size, but they have FTG avid. You can't ignore those. In fact, some of the guidelines, and we'll talk that a lot of malignancies will have malignant and then not light up. It won't be. You may have a lymph node that has just one part of the lymph node. This part of the lymph node is malignant. It might not light up. The guidelines say if you've got a node that looks suspicious, you should probably go ahead and take a look at that. The other reason we're doing the PET scan, what if the adrenal gland lights up down here? We got Adam Goldberg's favorite radiologic diagnosis. What is that? That's right, Gandalf. I'm not drawing it too good here. Like that. The adrenals. So look for Gandalf's hat, right? If it lights up, then needle that. So the PET scan helps you look for potential metastatic disease, and you want to biopsy the farthest point away so that you can diagnose and stage at the same time. So if the adrenal gland lights up, why should I biopsy this? If I biopsy here and I have an adenocarcinoma that immunologically by staining looks like lung cancer, I don't need to do anything up here. We've diagnosed stage 4 in one needle procedure without general anesthesia. That really helps the patient. That's what we want to do. So if there is a distant lesion, say in the liver, the bone, the adrenal, in the head, it gets harder, and that's where neurosurgery works with you. I see nodules and they ask us to look at it and they say, oh, they got something in the chest, but they got something in the head. I talk to nurse, they said, well, we got to take it out where it's located in the back posterior circulation. We got to take that out. So I don't need the biopsy. They take that out. It's squamous cell carcinoma of the lung. Adenocarcinoma of the lung, then they've staged and done their procedure. I don't need to do a procedure. So you always try not to do procedures. If you have that in your practice, always to try not to do procedures, you'll be safe. Always try to avoid trying not to do it. You do a procedure because you don't have a choice. You have to go forward to help the patient. You have a complication, it's okay. You have to go forward. Okay. If the mediastinal is avid, then you may want to do an EBUS along with that. So we have CT biopsy, we have navigation, EBUS, and radial probe. Let me talk a little bit about those also with the spin perk with the Baron navigation system. When would you use those? So let's go back to these questions. I try to see if there's a pathway to the nodule. Let's go back to this case here. If it looks like there's an airway going to it, I'll show you a CAT scan. There's an airway to that, and there's a lymph node that lights up. They shouldn't have just a CT biopsy. Why? Because you do a CT biopsy, the oncologist is still going to let you know that what is this? I got to have that. So now you got to go back and do EBUS. Well, I could do navigation and EBUS all in one procedure. Let's say the nodule's over here. Peripheral, but out there. Nodule, lymph node here. What would you do? If I see a pathway to it, I will still, with the Baron navigation, try to navigate out. If I can't get an answer at the rapid on site, I'll go ahead and do the EBUS turn the patient around and do a spin perk, we can do it in the same area, spin perk biopsy with the same data that we did to scan for the navigation. And so there are lots of patients who come that have a peripheral lesion and lymph nodes. They get a CT biopsy, then they come back around to EBO. So we can do it all in one procedure. And that's better. You can do everything in one procedure, it's better. You don't have to waste time and less risk for the patient. So I don't want to dwell a long time on the procedures, but let's talk about them. This is the CT biopsy here. Another picture here with the needle coming in here. Risk of pneumothorax depends on how many times they stick in. How many times you've watched the CAT scans, you see where they stick here, stick here, stick here to get it, and stick the lung several times. They go through. Many times it's not just one pass. Sometimes if they get it on one pass, many times you'll see they do a great job. And I think in general, what I've seen them do here, they do a very good job. But the risk of pneumothorax, they'll tell you is about 20 to 25%, 1 out of 4. I think it varies. When I see somebody new coming, I've had a 60% pneumothorax. They got 4 out of 6 on my first 6 ones when a new person comes. So it depends on the person, really, how much they're doing. They said, Dr. Bolt, you give me bad luck. I said, I'm sorry, you don't want to send you more patients. When it first he started out. So you have to know who's doing it. And in general, they do a good job here, but the pneumothorax rate generally across the board is about 20% nationally. With bronchoscopy, it's anywhere from 1 to 5%, depending on how you do. So it is much lower with the bronchoscopy. High-risk patients. You have a patient, as I told you, this is for CT biopsy. We're talking about CT. Multiple comorbidities, they're on Coumadin, they're on Plavix. It's hard to stop. It's going to be hard, and you have to be careful doing that. The location of the nodule and the apex can be hard to get to. Dr. Nichols sometimes sends me patients that someone has already sent to him for biopsy, and the lesion is right here. The nodule's right here. Well, it's next to the pulmonary artery. They can't look at that. They can't biopsy that because the only direction they can come in is this direction right here to get to that. And if they go beyond it, they're going to get in the vessel or right on near the aorta. They can't do that. Anything near the mediastinum, they can't biopsy that, or they shouldn't biopsy that. Sometimes you see them maybe try, some people try, but they shouldn't. It's too high a risk. Those patients need navigation or EBUS. So CT biopsy in the periphery. And as I told you, if it's a big peripheral lesion that has an airway to it, I'll try to navigate to it first, because frequently I need to look at the nose and I can stage them at the same time. 2 weeks ago, we had a lady had a nodule right about this location Dr. Sethi sent me to look at. It was right about here. And so the way of the location, wasn't able to do peripheral, but I was navigate, didn't get an answer. Looked at her lymph nodes, it was negative. We did the CT biopsy as an adeno. So she's going to get surgery. Went through that, but at least we had staged her. All right. So this is one of the navigation systems. You all know how that works a little bit, kind of just briefly. So what we're doing, we're taking the CT data, the CT scan that has the data where the nodule is. And I take that data and then I go down with a Super D probe that has a tip track that's gathering data, and I will put points on the main carina, the minor carinas, and go into the right upper lobe, middle lobe, lower lobe, and collect that data and superimpose it over the CAT scan, and you get a GPS map of where this nodule is. And then we'll start and navigate, and we have a pathway that it tells us. We have a virtual picture here, and it will show you to navigate. It sounds straightforward and simple, but it's not actually like that. It's a little bit more complicated than that, but it's been very helpful. Why do we have navigation? Why are we doing the procedure? Just to do it? No. Robotics is coming out also, and they're finding that it can be helpful. It's just in its early stages. We're still learning a lot about it. It's much more expensive, but it's also helpful. But what does navigation allow us to do? Before, and I say before days of navigation bronchoscopy, so we're talking before 2006, 7. It started coming out about 6, 7, 8 when it first started with navigation. EBUS came out about 95. So before that time, the only way you could get a lymph node was with a Wang needle, just going in blindly. So you're here at the carina, and the carina here. You had a lymph node here. It was easy to go into carina because it's not near vessels. But I would do the Wang needle down in the hilar area at 11R. And you stick the needle in, before you start jabbing, you have them aspirate, got blood, okay, I got it into the branch of the pulmonary artery. You gotta pull it out, can't jab that, right? So normally it's like a blood gas, it's okay, it's a muscular artery. If you've only gone in one time, come out, it's not major bleeding, but it's still a problem. You sure want to do that on the aorta or the pulmonary artery at level 4L, right here, where the pulmonary artery is. So that's where EBUS is very helpful. Really, EBUS is great because it's actual real time. I can see where the vessel is. Let me just show you. I'll get to that. It's down the road here. Show you some pictures, but you can see the ultrasound. You can see the needle coming in. You see the pulmonary artery here. You see big red here. You already have a lymph node here. You can see the needle coming in and where you need to go and watch so you don't put it in the vessel. The pulmonary artery, the main pulmonary artery trunk, is not real thick. It's not like the aorta. It's pretty thin. It's not generated for high pressure. So you can get problems if you hit that. So the EBUS is helpful, but the navigation, before navigation, we'd have a nodule. We wouldn't ever biopsy anything less than 2 centimeters because you got to look at it and see it on fluoro. And we would go with our needle with fluoro, using it with the plane. But if this is a nodule, is the needle here, here, or right in it? You couldn't tell. So the Super D has not only allowed us to go on 3 different planes to be able to see where it is, because you mark it in axial, coronal, and sagittal. You mark the nodule and you're actually seeing it in 3D. But you can get nodules. The smallest nodule I've gotten is 6 millimeters. We did that, not normally did, it was a carcinoid tumor, man at 6 millimeters. That's the smallest one that we've done. That's not normally what we would go after, but he was real nervous about it. He wanted us to go ahead. We found it was a carcinoid, and it was later taken out because it was growing and he had some bleeding, some other issues. But normally you would never go after a 6 millimeter nodule, and you couldn't go after a sub 2 centimeter nodule until we had Super D. So the early detection strategy that we talked about of not smoking and early detection is lung screening and tools to help us figure out, do we need to take it out? And this is changing. Oncology is changing faster than any specialty. The last 10 years that I've been here, cancer, oncology is changing faster than any other specialty. I have critical care, a lot of things coming, but not like oncology. Every day there's something new. We have a conference today at 5 about the robotics coming in, and we're going to talk about that, how it's changing. This is changing faster and faster to the point I don't have time to talk about all of it, but we have blood tests. I think when next 20 years, you'll come in, you'll see a nodule, you'll blow across the tube, yeah, you got an adenocarcinoma. Okay, now you still need biopsy? I think you will, because you'll have things that light up that you're going to need to stage. And you'll be able to detect the patient has cancer, but you won't exactly be able to tell them where all it is. Maybe, but we'll see. There is blood test now you can do, and it will pick in lung cancer. The problem was it picks up a lung cancer years, maybe 2 years before anything shows up on the CAT scan. So we don't want to just screen everybody that way. Right? So, I got a cancer. Where is it? Where is it? You can't find it. Can't find it. Gotta wait. That's raised anxiety for 2 years. So that's a real problem. So where is that blood test going to fit in? That blood test should be used in patients that have a small nodule and it's a high risk. You got a 5 millimeter nodule. Okay, we might take them out earlier. So that's all technology. It's coming. Technology is coming faster than we know how to use it. Right? And we see that as everything, even with our phones, right? Technology is coming faster than we know what the indication for it is. And so we see technology that might not have a very clear indication that's coming out. That's what robotics is about today. They're going to try to fit it in. We have robotics, but how does it fit in to the early diagnosis of lung cancer? Like the navigation, I think it has a place, but I think it's still version 1.0, and we'll see how it goes. This is the other system, the Veran navigation. So it has a tip track needle. When I've done the navigation, I will come out to the lesion. And it's interesting because if you have a needle and you have the needle in line for trajectory, it will turn yellow. And then if you have the needle in the lesion, it turns green. Not that the colors mean anything, but there's some tip tracking that helps with the Veran system. that I've been able to use on straight lower lobe and middle lobe lesions where my percentage detection has gone way up, where it was going maybe 50%, maybe 30 to 50 with Super D, with the variant going up to 80 to 90, been able to get. They're both systems are good. Variant system isn't good apical because can't make the turns. But this nodule here, you can use with the needle also, and it shows you in 3 different planes where the needle is in the depth. And this has been very successful. I use it more on pleural-based lesions, but you can use it in lesions that are within 2 centimeters of the pleura. So you have a nodule that you can't get a pathway to. You might decide to do a spin perk needle, and at the same time you're there, go ahead and do EBUS. So I use this when I have to look at the lymph nodes and I try to navigate, I can't get to it, then I might try a transthoracic needle with the same data that I got for the navigation. Okay, questions? So this is survival by stage. This is why we want to do early detection. Look at stage 1, lung cancer, 5-year survival. I have a patient in my clinic I've been seeing since 2004. He had a little lesion come up about 1 centimeter. It was FDG faintly. He wanted it out. 2004. He's still in my clinic today. He's about 82, 83. Took it out at stage 1. He's doing great. He has COPD. He's struggling with that, but he didn't die of lung cancer in 2004. He had a 1.2 centimeter lesion. No other nodes positive. They took it out. He's in this category right here, and he's doing great. But look how the stage drops off. You get below 2A, 2B, you go to stage 3, and the staging, a little more complicated than this, but just remember, what's stage 1 cancer? 1 spot, no nodes. Got a node high there? Stage 2. You got a mediastinal node, and how do you know it's a mediastinal node? The staging system for the nodes are single digits. So we have level 4, we have 7, we have 8, we have 9. Look out here, you have 11, 12, 13. They call them now just 11 R, inferior, superior. These are N1 nodes, these are N2 nodes. So you have an N2 node, 4, 7, 8, 9 positive, you've got stage 3. 3A, if it's on this side, if you have a N1 node on the other side, you got stage 3B. Okay, so 1 stage, stage 2 a node, 3B, why am I emphasizing that? That's a non-operative candidate. So you cross the operative line and you get to 3B. 3A, potentially surgical still with chemoradiation. And then see if they're at surgery. That's why I'm talking about that. And stage 4, of course, is somewhere else, outside of a pleural effusion included. So a patient comes in with nodules and they have a pleural effusion, tap the pleural effusion, do the cytology, see if it's positive. If it's positive for adeno, you stage the patient and help them out, and then they can get a Pleurix catheter and decide what treatment they need from there. Questions about that? Let's do some cases then. We have a few minutes. 46-year-old man, nauseated, confused, came into the hospital, serum sodium's 111. He had a plasma neuroosmolarity, found it had SI-ADH. And chest x-ray shows about a centimeter and a half nodule. So what do you want to do? What'd be your next step? Anyone? This is your patient. Okay, what do you want to know? Don't have any previous CAT scans. Symptoms he progressed, he's just been confused for the last week. Yes. 50 years. Yeah, then a little bit line, that wouldn't work then, would it? I had a guy, the earliest smoker I have had, 63 is the latest starter. Okay, age 2. This is young. His parents would roll the cigarette, stick it in his mouth. They thought it was cool. He had a cancer at about that age. But he started smoking at 2, so it could get 50 years, but he could get 42, 44 years at it, right? That's the record that I have. I don't know if you have any other than that. Yeah, so he's a big smoker. What I want to know is, yes, for the history, what would you do for your next step for diagnosis and workup of the nodule? Okay, so does the nodule need to be worked up immediately or not? I think that's an important question. Or not, because we get a lot of consults. Here, you get a CAT scan, okay? And there's your CAT scan on this patient. Does that need to be done immediately or not? Well, you have to look at the history. Can the patient have, you want to clearly correct his serum sodium. But is this driving that? Is there something driving that that might need to be attended to, that you can't wait and send him home as an outpatient? Okay, so that's part of the question. Is the process that I see there driving it? Here is the other window. Do you notice anything about that? So there's your two windows. Do we have previous CAT scans? I always ask. No, no previous CAT scans. So if you look here, and I don't have all the pictures to show you some additional history, look at his mediastinum. This is all abnormal. This is a contrast study. He doesn't have a pulmonary embolus, but what is this? If you look at this on other pictures, this area is kind of starting to go around and encase one of the pulmonary arteries. If you have a tumor encasing the artery, that could be actually an emergency. So you've changed it to an urgency. So he needs to have a diagnosis made as soon as we can get his sodium in a condition to get him stable to be able to do that. So based on that, we were able to navigate, and this is a radio probe ultrasound picture. I just showed that so that you can see when we were able to navigate out to the nodule. Once I get out to the nodule here with the navigation probe, I will then put a radio probe ultrasound that's looking. So it's a probe inside the airway. It looks to see if I can see that I'm in the mass, and you can see the mass here. If I have this view on a radio probe ultrasound, then the chance of biopsying that is very high, about 85% that you're going to get an answer. If I cannot see this and I've not navigated to it, you have to re-navigate. And that's a consistent problem we're still working on. But if you can't get the radio probe, what do? And we're still, that's where the fluoronav and some other things come on. But we were able to navigate out to that. And this area here is what I was talking about earlier. This is 4L. So 4L is between the aorta and pulmonary window right here. This is 4L on this side, 4R. So what do we see there? This is pulmonary artery right here. And this is aorta right here. And this is what? The mass or the lymph node. I rarely see 4L that big. It's just happened to be in this case. Typically you see for small, and it's difficult because you have to push a small node. You have to decide whether you can biopsy that. So that was his 4L lymph node, and there's the needle in it with EBUS. So what did we find? Small cell, that's right. So he got on treatment. Small cell's an urgency. It's growing fast, it's rapidly growing. That's why it's chemosensitive. And he got some radiation started to the mediastinum before he left the hospital. Radiation oncology urgent consult because it was encasing the pulmonary artery. What would be other urgencies? And this is what I think you need to know as an internist or primary care. When do you have a consult that needs a biopsy in the hospital? We get a lot of nodules that are in because they have a heart attack, they have a pneumonia. Well, we don't want to do a small little nodule thing. We'll see it with an outpatient. It's fine to get it in the system. But when do they need to be looked at during their admission? Well, in this case, so it's encasing the pulmonary artery. What else might be? Okay, you've got something blocking the whole lung. Now they come in, whole left lung is blocked. So you have an obstructive pneumonia. Maybe they have a pneumonia that's blocked, whole upper lobe. That can be dangerous. The timing of that is difficult. You have to decide. You just want to treat the pneumonia, have more antibiotics, but how long do you wait? Is it going to clear if you've got a tumor? So what we try to do is go in and make a diagnosis, but be careful when we're biopsying. They'll stir up pus with the blood. They're at risk for sepsis. That is an issue you have to balance. So an obstruction. What else? That one man came in and had an hemoptysis. That'd be another reason. Massive hemoptysis. We intubated him. I scoped him, had a big tumor in the right main stem. Dr. Geffler came over and said, can you get past it? Can you just look back? I said to just go past this so you could see where the HDR catheter pilots were gonna put. He said, okay, and I came out and started bleeding again. He was intubated already. It was bleeding so badly, tried to put up an effort, couldn't get it to stop. And he needed to be lasered, really, but he was on too high an F502 to permit laser. I don't do the laser anyway, us addition more of Dr. Bob did laser. We could do APC. Now, we didn't do it back then. So what did I do? Called IR. I said, can you embolize this patient? Laser back said, yeah. Took him right down, blazed back immediately from bronchial artery, found the blood supply to the lesion and what looked like a tree with a blush, finally became a tree that looked like it had been pruned in the wintertime. What he did to it, just took this whole tumor blush and it was just a couple of spikes. I went back in 2 days later, 3 days later, and it looked like that tumor that was all red and angry had been choked, and it looked like it was just pale and had shrunk back. And we were able to extubate him. He lived 18 months later, not due to the tumor. So that was again an urgent treatment where IR helped us with embolization on hemoptysis. So obstruction, hemoptysis, respiratory failure, pulmonary artery constrict. What else might be another immediate? Pericardial. Pericardial tamponade. You got big effusion, tamponade. You got to drain that. Had a patient had drained, it was small cell. We started chemotherapy. He never needed a pericarditis infusion. We just gave chemotherapy. We published that in the paper. Just gave chemotherapy and his effusion went away. He had a pericardial tamponade, a swinging heart. That's where I learned my electrical alternates. My first case when I was a resident. I wrote that. It just gets it's still to this day seeing his heart swing. And that heart's that's what gives it your EKG. If it has small cell carcinoma, that guy can't go home. So those are immediate issues that you need to deal with. Okay. All right. Let's go to this man, right upper cough, right upper chest pain, apical mass. Has that. What do you want to do? You did a CT scan. What would you try to do here? E-bus. You actually can't get to that with E-bus. From here, it's too far. The distance is too far. You'll see air, and air is the enemy of ultrasound. So this man, he's in for another reason. He had his gallbladder out, had some other issues going on. We saw him as an outpatient and had a PET scan would be the next thing you did. So we did a PET scan. Nothing else lit up in the mediastinum. He had an airway coming around to it. We were able to diagnose squamous cell carcinoma. There's your PET scan. Esophagus is going to light up some. And then he started on treatment. I think this is a 3-month CAT scan. You can already see it starting to shrink with XRT. DL, real quickly, I'm going to go through some other cases. This man presents with chest pain. Primary care did a CAT scan. He's got 2 nodules, one here, one there. So what do you want to do? He's 51, works in a factory, smokes a little bit, says 3 cigarettes a day. What you want to do? PET scan. I would. PET scan. If you look at this, you'll see it actually looks like it's necrotic. And it looks like there's an airway going to it. You see the airway coming? If you track that up, that's an airway lesion there. So here's another CAT scan. If you scroll down to another level below it, it's actually looking necrotic there. It looks like something else inside it. PET scan. There's your PET scan. What do you see? Anybody? The heart always lights up. This doesn't light up, this does. So that confirms that's the one we want to go to. So we navigated to it. There's an airway going to it. What did it get? Necrosis, just all necrotic tissue. So what do I do next? CT. CT scan, and he got his pneumothorax there, you can see. But it was just small, it didn't get any bigger. He was able to go home. What's CT show? It looks like it's in there. That's why they give you these windows. Necrosis and some granulomatous inflammation. Okay. Nothing's grown yet. I'm waiting still to see if fungus will grow, if TB will grow, MAI. If nothing grows, what do you do? But this, what would you do? What's that? He hasn't come back yet. He's supposed to come back this next week.
What about the other lesion?
Isn't growing. So I'm going to repeat the CAT scan. If it's still growing and it's not shrinking, we're going to take it out. So this man has 2 biopsies that showed nothing but just necrotic inflammation. Could it be cancer? Still could be. Could be. And if it's growing, I think I gotta take it out. I'm hoping to see if something will grow. If it still would grow, fungus would grow, I'd give treatment for it. If it continues to grow, you could say it could be, but if his pulmonary function allows us, then I would take that out. We'll watch both of them and see he's still in progress. Okay. I know we're out of time. Let me just do one last case here. Let's do this one. This is up to date. This is last week. Okay. 83-year-old man with history of carcinoma, right vocal cord 91, got XRT. Was fine until December. He got some eczema that acted up. He got prednisone, gave him abdominal discomfort, started bloating, came into the ER, had an abdominal CAT scan. What do you see? This is last week. Let's see. Yeah, lots of lesions. So what would you do? He didn't stay. They gave him some IV fluids. He felt better, went home and had that CAT scan. So what you would do, biopsy or PET scan? PET scan, okay. So here's the CT of the chest at that same time. You can see he's got a mass here. And here is his PET scan. The PET scan shows that nodule lights up. PET scan shows the liver lights up. What would you biopsy? Right, why? Exactly, he's a smoker. So we biopsy. And they say malignant, adenocarcinoma, but the immunostain say GI origin. That didn't fit. Now what's going on? So what should we do? This is just last Friday. What's that? That's set up, yes. But what would you do with this middle lobe? He's got a middle lobe lesion here.
What about that lesion on the kidney?
That's not a lesion, that's just the collecting system, nothing on the kidney. The vocal cord actually lit up too. It's good call, good question. But he's got this. So Dr. McDuffie sends him to me and says, I gotta know what's in the middle lobe. So I biopsied him Monday. Today's Wednesday. Came back yesterday. Guess what it is? Squamous cell. So he had a vocal cord lesion that was hot a little bit, but ENTs looked at it, said they don't see anything on the vocal cord because he had a squamous cell, we presume, back in 91. So is this metastatic laryngeal? I don't think so. We still haven't figured it out yet. I looked at all his lymph nodes, negative, but he's got a squamous cell in his lung and he has a adeno in his liver. So we still don't have the adeno figured out. So this is just a case of multiple cancers that sometimes you'll see and what we have to go through. And so have a couple other interesting cases, but I think we don't have time for that. This is last case. If a resident wants to work with me on this case, then we can write it up. This man came to me from Dr. Jong's office. That's his chest x-ray. Here's his CAT scan. He says his right middle lobe, there's something blocking it. He's short of breath a little bit, nothing else. I have a previous CAT scan that shows something's there 3 years ago. Now it's blocking it. So Dr. Jong asked me to look. He said, something's growing there. PET scan, negative, but it's blocking his right middle lobe. So I look and the whole right middle lobe is occluded. I pick in a forceps and pull it back and find it's open and start biopsying around the area. It looks a little abnormal. And there's your biopsy. What do you see? 44 years old, non-smoker. What is his deposits? Some proteinaceous deposit here. See it here? Look at this slide here and then look at this. What is that? Congo red, green by refringence, amyloid. I've never had a case of pulmonary. I had heard maybe one case that I had in my whole career, Dr. Jong, also pretty rare. So what are we going to do? Oncology is trying to help us decide what type of amyloid it is and what we're going to do. But it's an interesting case. So I was going to write it as a case report, but I'll open the opportunity to one of you all who are interested who want to write it up with me. She did. All right, good. Good. I have another case too that's interesting, and I'm not gonna have time for that. We could keep going on strange cases. But if you're all interested, I have some. So if you'll get with me so we can talk. Whoever ever raised their hand on another one, I have another case. But pulmonary amyloid is pretty rare. So I think what we'll do is a review of the literature and then present this case report. And interesting, it's good for y'all to get publications like that. So we'll write it up together. Questions? All right, thank you very much. I think I'm in my profile, I think, or yours. What was his hand?
Diaz.